Hi everyone. Today I'm going to share with you an interesting case I came across at the clinic. So this is a 71-year-old male, a veteran who served in Guam for 3 years and got exposed to Agent Orange. So the patient came walking to the clinic with a crane, walked slowly. He told me he has CIDP, he has pain, and he wants me to hear his whole story, which I am happy to listen to. So the story started in 2007. The patient fell in garage with his legs giving out, during which he was unable to stand, unable to walk, not able to use his hands. Also reported loss of balance at that time. He was hospitalized for 2 months. Since then, he developed chronic pain in upper limbs and lower limbs, especially the fingertips. So in the exam room, the patient held this gesture to try to protect himself because he is concerned someone could come to randomly to shake his hands. And he has pain in his, especially in the fingertips. And when I tried to examine him, he said he needs to adjust his gesture to make him feel less pain so that I can examine him. He also reported more numbness in left hand compared to right hand. And he reported neurological itch for 7 years, but completely went away 6 months ago. So when he was having the neurological itch, he had high dose gabapentin, but the itch remained unresponsive to medication. He managed the symptoms using ice packs and cold water. No vision blurry, no dysarthria, no swallowing difficulty. Additionally, he reports bilateral anterior thigh pain and emphasized that he has no pain at all on the back of his thighs. He also has numbness in bilateral lower extremities below the knees. So here we have the picture in our mind that this is acute onset and both motor and sensory are involved. The sensory pain and numbness doesn't fit into any dermatomes. Another red flag here is that the patient told me he has no pain or numbness in the night because he believes the nerves went sleep with him in the night. Going to the partial medical history, the patient has asthma, hyperlipidemia, type 2 diabetes, hypertension, sleep apnea. He used a CPAP machine, and he developed dry mouth after using tramadol for a long time. He had surgeries in both right and left shoulder. Gallbladder removed in 2015. Family history non-contributory. Patient also reports resolution of asthma symptoms after receiving IVIG for CIDP. I think that could be a coincidence or could be a placebo effect.
Why?
So then I did the neurological examinations. Cranial 2 to 12 are intact, and sensory pinprick inconsistent. He has pain in anterior thigh and numbness below bilateral knees. Vibration decreased, proprioception intact, and lumbar sign is vague because he's not stable when closes his eyes, but he didn't fall. Coordination normal. Regarding the motor, so the patient walking with abnormal gait, but the gait doesn't fit into any pathological gait. And he's very slow when he tries to rise from sitting position, and he does sway when he doing the tandem walking. No increase in muscle tone, no rigidity, no spasticity. Of note, this patient has no weakness on the muscles that I examined, and the patient told me that he is very strong. He can lift me up. Reflexes is decreased. So based on the history and the neurological exams, I don't think this is CIDP, but I don't want to miss anything. So I go back to check the CIDP diagnostic criteria. So the 2021 guidelines, they're based on patient's history and physiological examinations to classify patients with suspected CIDP as typical CIDP or CIDP variant or atypical CIDP. And it has sensitivity of 83% and specificity of 94%. So for typical CIDP, individuals need to meet all three criteria below. So chronically progressive or relapsing, symmetric, both proximal and distal involved, both motor and sensory involved, at least 2 limbs, at least 8 weeks, diminished or absent reflexes. For CIDP variants, or can be called atypical CIDP, individuals need to meet at least one of the following criteria. If it is distal CIDP, so the proximal extremity are spared, both motor and sensory involved, predominantly in lower limbs. If it is multifocal CIDP, then it is asymmetric, upper limb predominant, both motor and sensory involved, at least 1 limb. If it is focal CIDP, both motor and sensory involved in only 1 limb, or it can be pure motor CIDP or pure sensory CIDP. So this is an illustration of what we just talked about. If we suspect CIDP, according to the guidelines, the CIDP can be diagnosed with a typical CIDP or CIDP variants. For typical CIDP, both motor and sensory involved, both proximal and distal involved, and it is symmetric. Distal CIDP, proximal spared, both motor and sensory involved, predominantly in lower extremities. Multifocal or focal CIDP, asymmetric, both motor and sensory involved, predominantly in upper extremities. Or it can be pure motor CIDP or pure sensory CIDP. Once the clinical criteria are met for typical CIDP or CIDP variant, we can go on to the next step. So we can have the patients to have some tests, nerve conduction test, and lab tests including lumbar puncture, SPEP, light train, to exclude other possible like hematologic malignancy or amyloidosis that could also manifest with neuropathy. And we can have the patient try to do the MRI imaging to see if there are enhancing or hypertrophy of the nerve roots. Then based on the results of the tests, according to the criteria, we can diagnose the patients with CIDP or possible CIDP. So the 2021 guidelines only have CIDP and possible CIDP diagnosis now. The older one, the 2010, it has CIDP, probable CIDP, and possible CIDP. But in the newest one, the probable CIDP has been excluded. This patient had, fortunately, I find a nerve conduction test of this patient done in 2017. So we see here, no evidence of acquired demyelinating neuropathy. Diagnosis is sensory neuropathy. It could be the patient has long-term type 2 diabetes. It can be related with that, or it can not be related with type 2 diabetes as well. There was a research done in 2015 published on Neurologic, an interesting research. So they find the misdiagnosis of CIDP can be as high as 47%. So it's common. The misdiagnosis is common. So far, we can be sure this patient is not CIDP. The diagnosis is not CIDP. Well, I think this patient has functional movement disorder. So let's take a look at the clinical characters of functional movement disorder. It's abrupt onset this patient has acute onset in 2017. Faster progression to maximum symptom severity and disability. He cannot stand, he cannot walk, he cannot use his hands. And the movement of abnormality is incongruent with any known diseases. And presence of comorbidities. So this patient has type 2 diabetes, hyperlipidemia, and he served in the veteran. He may have PTSD as well. The general principles to diagnose functional movement disorder. A mistake I made before is that I think functional movement disorder is a rule out diagnosis, but then I get to realize that it is a rule in, not rule out. So functional movement disorder is not a diagnosis of exclusion. Comorbidity. Coexisting psychological factors and psychiatric disorders are not required for diagnosis of functional movement disorder. It can coexist with other neurological illness, or it can coexist with other movement disorders. And lab-supported diagnosis with electrophysiology can be used in challenging cases. Interestingly, so misdiagnosis is rare. So I've read a research paper, the misdiagnosis rate of functional movement disorder is 4%. I think it's that this is interesting because the misdiagnosis is not that high as I imagined. So as I mentioned before, the patient hold this gesture to hold this position to try to protect his hands. We may think either dystonia. So fixed positions are rare in non-functional dystonia. And the positions typically display patients display marked resistance to passive movement when the limb is at rest. So this patient doesn't. He is very flexible and no spasticity, no increased muscle tone, no rigidity. Treatment can be difficult for functional movement disorder. So there could be a question whether we should bring up this diagnosis. The first step, all patients should be provided with a diagnosis, education, and advice. And patients with more severe symptoms but without complex psychiatric comorbidities may benefit from physical therapy, occupational therapy, speech therapy, with or without accompanying psychotherapy. But patients with complex symptoms, presentations, and high level of disability and comorbidities, usually the treatment can be very difficult. Regarding the prognostic factors in functional movement disorder or functional neurological symptom disorder, here are the positive prognostic factors: onset in childhood, in early age, early diagnosis, good response to initial treatment, comorbid anxiety or depression, subsequent changing in marital status, and good therapeutic alliance with the clinician. Here are the negative prognostic factors. The patient we see here, he has multiple physical symptoms: pain, numbness, initially unable to use his hands, unable to walk, unable to stand, and longer duration. It has been a long time since now. The pain and numbness, especially the pain, are still there. Believes that symptoms are irreversible and caused by disease with a known pathological basis. So the patient told me he got exposed to Agent Orange, and he has the strong belief that this is the reason why he got CIDP. Illness-related financial benefits. Yeah, I want to thank you, everyone for this great opportunity to work with wonderful peers and our medical assistant in the front desk. And I really want to thank you for these precious opportunity that Dr. Stein and Dr. Bernard gave me so that I can take history and exam patients and write notes myself. I really appreciate. Thank you, everyone.
Okay.